Well, good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. It's a beautiful day out there, as always, and I'd like to welcome all the 150 people that are logged on. Celeste van Drünick is a person that needs no introduction because she's been on this platform with us. Celeste, there you are. You certainly don't need an introduction because you have been introduced before, and it's great having you here with us. Celeste, because we've been before together on this platform, is a person who is a gynecological oncologist. She trained at the University of the Western Cape, the University of Tygerberg, and she works at the Vincent Pallotti Hospital as a gynecological oncologist. Celeste is a private practitioner, so she does travel between the hospitals, and she's just noted that there are many hospitals in the Cape Town area that use her skills for difficult oncology and even for difficult cesarean sections for placenta creta, placenta precreta, and when the placenta goes rogue. It's wonderful. Yeah, it's wonderful to have you, Celeste. Our co-host this evening, my name is Peter de Jong, and our co-host this evening is Professor Steve Jeffrey, except that he's just been called away for a gynecological oncology emergency, and him being the ureter and bladder man, unfortunately can't be with us tonight, but we wish him well in his endeavors in the gynecological oncology emergency scope. So Celeste van Drünick is a person that's going to be speaking to us about the diagnosis and staging of endometrial cancer. It's wonderful to have you again with us, Celeste. Would you mind, Celeste, if people pop up questions, as they always do, if you answer them contemporaneously as the time comes up, or would you prefer us to bank them and keep the questions till the end?
I think let's keep the questions to the end because I'm not going to have a very long talk because it can get very complicated, and I don't want to make oncologists out of everyone here tonight, So I'm going to go through just the basics and then we can do some questions after because there will be time.
Okay, that's fantastic. So we will have, ladies and gentlemen, there's nearly 200 people logged on. So your talk has gone viral, Celeste. Wonderful to have this. And it shows you the level of importance and the level of interest in this particular topic of diagnosis and staging of endometrial cancer. So without further waste of time, Dr. Celeste van Drünick, over to you.
Thank you. So this is just an overview, a reminder of endometrial cancer from diagnosis, risk factors all the way through. And when it gets more complicated, I'm not going to go into too much. If there are questions about management, of course, we can go into it afterwards in the Q&A. So let's start. Prevalence of endometrial cancer. It's actually quite prevalent, as we know, in first world countries. The 6th most common cancer in women and 15th most common cancer overall. These are just a stats. I'm not going to bore you with stats. Incidence and mortality differs in depending where you are in the world. Of course, we know different statistics in different areas are actually, sorry, I don't know why it advanced. Depends on how accurately it's documented or recorded. We know that endometrial cancer, usually when it's picked up early, as it is, there's a very good 5-year survival rate. Can you see my pointer, my mouse?
We do see your mouse.
Okay, great. So in South Africa, it's actually more common than we think. And I'm going to get into why now. But if you look at this graph in South Africa specifically, yes, we know breast cancer is the most common. These are all the others that's not the most common that's grouped together. Cervix, we know, is a big problem. But after that, endometrium lies here in the on the turquoise wedge here, and it's the 5th most common cancer of cancers in our country and amongst women, so about 3.6% per year. There's a big ethnic disparity in the mortality, actually, unfortunately, in South Africa. This is a study that was done by colleagues of ours, and they actually showed, Shane, the annual deaths. Unfortunately, Black women and overall, it's much higher than other populations. That could be attributed to many different things, but it's just important to note that. When we get to obesity and endometrial cancer in South Africa, just overall, if we look at BMI or obesity and overweight in women in South Africa, you can see here it's actually quite astounding. More than 40% of South African women are obese. That's a lot. That's a big number. And if you look here to the side, 70% are either overweight or obese, and it's actually increasing. So that's very alarming. And why is this important? Because the lifetime risk of uterine cancer in South Africa is 1 in 140, but it depends on which type of endometrial cancer, occurs. So in the old days, some people still talk about endometrial cancer, and that's the EC, that's what it stands for. Type 1, these are the ones that are estrogen driven, usually the lower grade endometrial cancers. And as you can see, how your odds ratio goes up just with being overweight. You've got an increased odds ratio of 1.5 just with being overweight. So 1.5 times more likely to get endometrial cancer than baseline. And as the BMI goes up, you can see a massive odds ratio of 7.1. And a lot of people think it's only for these type of cancers that obesity will affect the numbers. But when you look at the type 2 cancers, the high grade ones, the aggressive ones, right? Your risk is also increased if you have a higher BMI. And significantly so, odds ratio of 3.1, 3 times more likely if your BMI is above 40. So this brings me to the other risk factors. So obviously we know metabolically and lifestyle. Obesity, the theory is that there's an increased risk for endometrial cancer because of increased peripheral estrogen. But it's not only that. It's also to do with increased inflammation, genetic, and there is a geneticist online. You can go into exactly what happens when there's more inflammation and more adipose tissue. That also increases your risk for other cancers. Lots of this is then to do with obesity, high BMI, inflammation. Apologies, I don't know why it's gone back. Then we know unopposed estrogen, as I said, and these risk factors all play into unopposed estrogen or increased or high levels of estrogen without natural progesterone opposition, like in PCOS, when you're not ovulating regularly. Medications, of course, we know there's a risk factor with tamoxifen in postmenopausal women. And of course, if there's been estrogen-only treatment for a long time. Then when we get to the genetic risk factors, something like Lynch syndrome definitely increases the risk for endometrial cancer, and a strong family history of endometrial colorectal cancer playing into this, or the possibility of there being a Lynch syndrome or mutation increases your risk for that. And then any increasing age and then prior pelvic radiation when you still have your uterus intact slightly increases your risk as well. Okay, so what about screening? We know that the numbers are going up. We know that obesity is going up and all the things related to that, the diabetes, the PCOS. So should we be screening average risk women? Okay, so average risk women, they are classified as average risk when there's no known high-risk genetic condition like Lynch syndrome, and they don't have any symptoms, so they're completely asymptomatic. We'll go into symptoms soon. Throughout the world, ACOG, NCCN, ESCO, so Europeans, Americans, everyone feels that routine screening is still not recommended. But all women should be educated about symptoms. Now, that's a story for, or an argument for who should educate them. Should it be schools, the government? Who knows? But they should be educated. And when you see somebody, it's good to tell them about abnormal uterine bleeding or postmenopausal bleeding, risk factors. And they should know that if symptoms arise, it should be evaluated promptly. Women often, I've seen it often that they think they were postmenopausal for a year and a half, so no period and the appropriate age for a year and a half. They're obviously not pregnant, they're 50. And then a year and a half later, they got a period. And a lot of women say, oh, but I thought my period just came back for once, and that's not what patients should think. They should really worry about postmenopausal bleeding, and it's us and a lot of other people's obligation to educate them about postmenopausal bleeding and abnormal uterine bleeding. So what about high-risk women? So these are the ones that are my mouse keeps on going back for some reason there. The Lynch syndrome carriers, the ones with a very strong family history of endometrial with colorectal cancers.
Okay.
So then you need to discuss possible screening with them. It's a discussion. It's not a must because the benefit of screening is not firmly established, right? But the discussion can be around, should we biopsy yearly? Should we do an ultrasound at a very non-specific CUA 1 to 5 from probably the age of 30 to 35? So the exact frequency, age, modality, it depends on the genetic risk, the history, where you are, where you are in the world, what you have available, and obviously patient, if they're funded or not funded. And also the patient's risk factors. That's very important that you also keep that in mind. So what is a workup? What should we do? Okay, a lot of times, and we still see it and we still discuss it at our MDT, if there's a woman that presents with postmenopausal bleeding, they've had a scan and the maybe didn't look very significant, they've had a transvaginal ultrasound for the endometrial thickness and it probably looked 4 millimeters. I don't know, I can't say, but we see it often that they presented with postmenopausal bleeding, and this diagnostic confirmation with a biopsy or hysteroscopic biopsies were not done. And patients are jumped immediately from, oh, okay, I've done the scan. I couldn't really do the sampling in rooms, or I'm not going to do hysteroscopy. Let's just do a hysterectomy for you. And then you get a surprise. There is an endometrial cancer, and then unfortunately there's more than 50% invasion into the myometrium, and then you didn't do lymph nodes. And then it becomes very difficult to know, should we give adjuvant treatment and treat lymph nodes, which includes, and we'll go into that, but a long 6-week course of radiation with some chemo. Should we go back and take the lymph nodes out then? Of course, we look at different things when we want to assess lymph nodes, and I'll touch on that as well. But it is very important that we follow the rules, the basics, okay? So, history, pelvic exam, risk factors. For who? Anyone above 45, as we all know or should know, that's the old rule, above 45 with abnormal uterine bleeding, that's persistent, that's not responding to treatment, that you can't attribute to a withdrawal bleed from missing the pill or something like that, that's straightforward. You need to investigate and you need to try and do an endometrial biopsy. And even more so in somebody, even if they're less than 45, if they've got risk factors. The patient with a BMI of 50, that's 35, that's bleeding for 6 weeks on end, you can't really understand. She has a Mirena in, or she had one, but you need to investigate that patient. She's got a massive risk factor for endometrial cancer, as I showed you, or odds ratio that's increased. Rather over-investigate in a way, and somebody that it's not really over-investigating, but rather investigate it and find nothing than not investigating and giving them the wrong management or missing an endometrial cancer. So we need to make a diagnosis. You need to do the biopsy, whether it's in rooms. Just as a side point, if you've decided I need to do endometrial biopsies and you want to do it in rooms, that's fine. It's acceptable. Sensitivity is high enough. Sensitivity, as a reminder, is the ones that are really positive is positive. That's high enough, okay? But there is a high failure rate, 11%, okay? So what do you do then? Do you then leave it? Oh, I can't do the biopsy. The cervix is stenotic. Sorry, postmenopausal lady. But it's okay. No, you've decided you wanted to do endometrial sampling or biopsies. Then if you can't, get into the cervix and get those biopsies, or your results show that insufficient tissue, they can't really say, the pathologist can't see, then you should do a hysteroscopy. Okay, that must be the next step, because you've already thought about doing biopsies, you already tried. Just because it failed doesn't mean you can give up. Okay. Then once it's confirmed the cancer, you're going to do your basic imaging and bloods. Basic bloods, it's important that we know where we are. They've been bleeding. You need to know what their HP is, and renal and liver functions to see if there's any spread potentially or affect baseline, see preoperatively if they're optimized or not. Okay. Then when we get to imaging, depends on where you are. In private practice, sometimes it's easy for us to get an MRI, which is the recommended one for localized staging. Okay, so you've obviously examined your patient initially. You don't think it's an advanced metastatic cancer. When you think it's probably early, it's just something that's coming from the endometrium on your scan, then an MRI for local staging, if you can get it and if it's affordable, then that's ideal. Okay, and some centers in the world, they say expert ultrasound is adequate, but it needs to be somebody that really knows how to look for myometrial invasion. Okay, that's what we're looking for, to see. One of the things is to see if we need to do lymph nodes and assess the lymph nodes. Okay. In resource restricted areas, they do chest x-rays and abdominal ultrasounds to screen for metastatic disease in the liver, and they try and see for lymph nodes, but we know it's not very accurate, but it's what they have and they use that. But a CT chest pelvis is actually better to look for spread or, systemic spread. And if you can get it, you need to get it. She's been diagnosed with an endometrial cancer. If you've got the funding, you can do it. Okay. So MRI incidentally is also better to look for lymph nodes that are already pathologic than a CT scan. Okay. Then preoperatively, so we're planning for surgery. Usually we want to do surgery for endometrial cancer. So we want to evaluate their comorbidities and their surgical risk. We want to optimize what we can within the short time frame, a week or two or whatever we have. We want to plan the surgical staging. But importantly, we need to discuss this at a MDT meeting. Okay, this is really what once again, all of these guidelines say that we should do. Once somebody is diagnosed with a gynecological cancer and you've done your workup and assessment, they need to be discussed. Is surgery the right thing for them? If we're going to operate, should we do lymph node assessment or not? Okay, so these are we look at the imaging, we decide with the whole picture, what is the next step? Okay. Before we continue, just a quick reminder, the histological subtypes. So we get a type 1 or the low grades that I mentioned earlier. These are the endometrioid cancers. And now we've actually come to know that there are molecular subgrouping, which is very intimidating even to me when I started hearing about this 2-3 years ago. But you can actually now classify them in the molecular group, and I'll go a little bit into that without being too technical, but usually these ones have the good to excellent prognosis. And then you get the type 2 or the old type 2 or high-grade cancers, different histological subtypes, and usually they are P53 mutated, so abnormal, these ones. Okay, and usually the prognosis is not very good. Okay. So this is the 2020 molecular classification where they integrated the cancer genome atlas findings, which was amazing finding. And we actually now know a lot more about endometrial cancer. It's not as straightforward as type 1, type 2 anymore. It's just not, okay? So once again, they've now made beautiful colors for us, a rainbow, and there's even rainbow studies ongoing to seeing different molecular subtypes of endometrial cancer. If we do certain interventions or adjuvant treatments, what are the actual outcomes, okay? So POL is good. If you hear POL and it's mutated, it's usually low grade, and that's very good. It's always reassuring, and the prognosis is excellent. Then you get this MMR. It becomes tricky usually when it's endometrioid and it's grade 2 or grade 3. We don't know how this tumor is going to behave. Then a lot of times we need to check, or the pathologists check this. And actually there's now guidelines that if you can check molecular subtyping on endometrial cancers, you should. The pathologist can do it, and it's affordable in wherever you are, you should do it. Okay. P53, which is not an expensive test for the pathologist to do, should be done, because as soon as that's abnormal, we know that that's a high-grade cancer. It doesn't matter what the subtype is, because you can get a high-grade endometrioid cancer. They behave completely differently than the low-grade grade 1 endometrioid cancer. And then if they don't fit into these molecular subtypes, then you get the non-specific molecular profile, usually low-grade endometrioids. This is what it looks like, and the prognosis is intermediate. So if you look at these overall civility, these curves, you can see. So this is just how they decide about testing. If you have POL is very expensive, but it is available in private practice. As soon as you have that, you're sort of, okay, great, it's a POL mutated cancer, and that's very reassuring, and it can change management as well as not only prognostic. Okay. Then if you have this, the MSI or the loss of this gene, MSH or BMS, is usually associated with the Lynch syndrome patients that have that genetic mutation. And then when you get the TP53, we know these are the high-grade ones that usually are not behaving very well. And if they don't fit in there, it's the non-specific ones. As you can see, prognostic. So this is the POL, excellent survival. Here we go, non-specific, so they don't really fit in anywhere. A little bit less, but not bad. The MMR ones, the Lynch ones there. And then when you get to the P53, the high-grade tumors, survival is not that great over 5 years. Okay, this is a very intense staging. I've made it very small so that nobody can read it on purpose, because it's really complicated. And you can just see all the little extra things they've written here at the bottom, explaining what they mean and this and this. It's really complicated, and we probably have to look it up at every MDT. What is the staging if it's not very obvious, a 1A or a 4C? So it's changed. It changed in 2023, and it's something that we still struggle with, and there's been a lot of critique because they brought in the molecular subtyping, but they say that it helps. So yeah. So this is just to show you, this is the old staging, not too complicated, and now quite complicated. And if you look at it this way in a beautiful butterfly, it was actually not that bad, the staging, and now we've got all these subtypes because we've got the molecular stuff on board as well. Because of that beautiful butterfly, I thought I'd put this in here. A group of butterflies, I did not know this, is called a kaleidoscope, a flutter, or a wing. So if you see a group of butterflies, you can say, what a beautiful wing of butterflies. Okay, so this is not a very beautiful butterfly, but it gives you a surgical approach. So if you think that the patient has early stage endometrial carcinoma, you've done your workup, which I advised you to before. Usually you want to do surgery. That is the gold standard where we start. And what are we going to do? We want to do a total hysterectomy. You can't do a subtotal hysterectomy because we need to know if the cervix is involved or not. You don't have to do a radical hysterectomy and take margins wide around the cervix. That's not proven to make a difference, even if there is cervical involvement, but a total hysterectomy. Then you add both the tubes and the ovaries. Except in a stage 1A grade 1 patient that's less than 40, you don't have to remove the ovaries. You can preserve the ovaries and just remove their tubes. When are you going to do an omentectomy? When it's high-grade histology. What about lymph nodes? Well, you don't have to do anything, usually with a stage 1 low grade, and you don't think there's any myometrial invasion. But a lot of times we do get a surprise. We don't think there's any myometrial invasion on the MRI that we discussed. We pulled up the beautiful MRI on the screen at our MDT, and then we do get a surprise. Or they thought it was grade 2, but now it looks like grade 3 endometrioid. Can happen. Then we've not done lymph nodes. Then we're also in the scenario about what should we do. So there's a big argument for, and a lot of oncologists and gynae oncologists are arguing for doing more sentinel lymph node biopsies because the morbidity of it is much lower than doing a full lymph node dissection. And so it also depends on where you are, if you have the dye available, the filters available, if you've been trained to do it or not. But there is an argument for it if you're able to do it. Even in stage 1, grade 1 to 2, there are studies ongoing to see in higher grade cancers, can we use it? Should we use it? Well, as long as there's not big pathological lymph nodes, you can and should use it then. And then what is the route? So I said to you before, minimal invasive surgery is the way to go. We know that it does not decrease the outcome of, oncological parameters like overall survival or progression-free survival. Sorry. There we go. In some cases, you can't do minimal invasive surgery. The patient's not going to tolerate it. You don't have the equipment, the skill. It's not ideal. If you can refer to somebody that has the skill to do minimal invasive surgery, and what you want to do, including lymph node assessment, even if it's a full lymph node dissection, then rather refer the patient. It's very important. But yes, there is a place for open surgery. If you think it's slightly more advanced, there could be many different reasons there is a place for it. Okay, I've put vaginal in brackets here. Small place for it. The old 90-year-old that has endometrial cancer, she keeps on bleeding. For some reason, she can't lie still for a single fraction of radiation to stop the bleeding from an endometrial cancer. You can consider, doing it maybe under spinal or sedation or whatever, and then you do vaginal hysterectomy. But that's not really how we do it because you can't assess the abdominal cavity or the lymph nodes. Okay, I'm not going to go into detail. As you can see, adjuvant treatment after you've done surgery and you've fully staged the patient is quite tricky, okay? But basically, patients are grouped into low risk, intermediate risk, high intermediate risk, and high risk. Low risk, they don't need anything. And interestingly enough, also now, if you see that somebody has pole mutated cancer, if they were stage 2, you can actually downstage them to stage 1. It actually can change the staging in stage 1 and 2, which is very helpful and interesting and can save patients that extra adjuvant radiation. As soon as it's a little bit more gray, there's, let's say, higher grade histology or the LVSI, that's the lymphovascular space invaded, or some stage 2, they're above 60. We start thinking about just adding Volt brachytherapy, okay? But there's also a place where you don't have to do it when they're less than 60. So this we always discuss at our MDTs. It's very difficult to decide. We have to look at the guidelines probably every time because there's so many little things you have to look at. High intermediate risk, usually external beam radiation. And then if they're high risk, and this has not changed. Before it was, stage 3 onward, you would do full pelvic radiation with the chemo that you add on. But now actually they've changed this with the new staging. So all stages, even if it's stage 1B, okay, and all histologies, but if there is P53, so it's a high grade cancer, okay, and myometrial, as soon as there's myometrial invasion and it's a high grade P53 abnormal, you have to give full what we call PORTEC-3. Those are the, remember the practice changing studies, full 6 weeks radiation with concurrent chemotherapy and a bit of Volt brachy, depending on where you are. Okay. This is just to show what other options there are for, as soon as it gets advanced or recurrent. I'm not going to go into that. Something that I just want to touch on, I think is actually very interesting, is immunotherapy. A lot of people have been talking in cancer treatment about immunotherapy. And it was very intimidating for me when I heard about immunotherapy and how it works. But whenever I hear immunotherapy, I always think about this little cartoon. So how it works is, it's just very interesting. I'm just going to share it with you. So how it works is on a T cell, your immune cell, okay, and a cancer cell, the pink one, there are checkpoints or these receptors, PD-1 and PDL-1. Right? So cancer is very clever. Cancer knows how to evade the immune system. That's how it became cancer. It hid or whatever. And so they fight back. As soon as the T cell sees, wow, this is an abnormal cell. He's very pink or very red. He looks weird. He wants to kill the cancer cell. But once they recognize this receptor, the cancer cell, the PDL1 and the PD1, they can actually kill or make them dysfunctional, this T cell, so that they can escape and they're not killed by the T cell. They're like a very bad villain, okay? But what does immunotherapy do? It's a PD1 and you also get PDL1 blockades, okay? It's like a helmet or a protection against for the T cells, against the cancer cells, making them inactive and not do their job, okay? So they can't harm the T cells anymore, and so the T cells then can get rid of the cancer cells as they would have wanted to initially, okay? So there's new evidence coming out, a lot of evidence about immunotherapy in gynae cancer. There's a lot for cervix cancer, and now we also see pembrolizumab for endometrial cancer, and there's lots of studies that I'm going to not bore you with, but it actually shows that there is evidence that it improves outcomes, specifically for those patients with the Lynch syndrome or the MMR deficient MSI mutated tumors. But it's expensive, you need to monitor them for toxicity, so it's not without its adverse effects and issues. Okay, so this is just a summary. It looks very complicated, but I've basically said all of this. You're going to get your initial diagnosis on a biopsy or on your DNC hysteroscopy biopsy. You need tissue diagnosis, histology. Okay. Stage 1, we're always going to do surgery. There's different things we can do. This needs to be discussed. If you want to do any fertility sparing or it's not straightforward, discuss. Stage 2, still surgery. They might need adjuvant vaginal brachytherapy depending on the final histology and molecular subtyping. Depending on the stage here, 3A to 3C, usually you'll still do surgery if you can. And then you'll add your adjuvant chemo plus minus radiation. And then this is very personalized. The recurrence, okay, here we're talking about hormones, so anti-hormonal treatments like your aromatase inhibitors, progestins, and then you also get the immunotherapy. And that's what I have to say.
Celeste, that's wonderful. Absolutely wonderful. Huge applause from the hundreds of people that have logged on. we do have some questions. May I kick off and fire away?
Yes.
Okay. Now, you mentioned, and it has been mentioned before, that people that have abnormal bleeding towards the menopause should be investigated. But the problem is, apparently, in terms of this question, there are many hundreds of women that are perimenopausal that do have bleeding. Should they all be investigated, perimenopausal women, those above 45 or even earlier if they have risk factors? Or is a scan and other forms of management permissible? Would you investigate basically all perimenopausal bleeding with abnormal periods?
So I would be very careful to say yes to all, because medicine doesn't work that way. We know that. You need to individualize and personalize. ACOG, I forgot to say this, the Americans brought out, ACOG, brought out new guidelines for postmenopausal bleeding, but this is now postmenopause, where they say we're not going to go on the 4 millimeter threshold on the ultrasound's endometrial thickness any longer, because you will miss a significant amount of cancers, even if the endometrial lining is 3 to 1 millimeter. Okay, so they advise now, they've actually changed all their guidelines, or the guideline, the major one, that says you have to do tissue biopsy as well. So a scan is not good enough to say, oh, it's less than 4, fine. Okay, we don't have to biopsy. You still need to biopsy that endometrium. So I have actually brought that into my practice. I think, of course you're going to use your judgment. If it's somebody that a little pink wipe, and yes, it's 1 millimeter and she's 89 years old and she's not fit for a hysteroscopy, you're going to use your judgment. But in perimenopause, it does become very difficult because they do skip periods, and that's really, perimenopause's issue. And then sometimes when they do get a period, it is heavy, okay? But I feel if it's weeks on months on end, you've tried or changed, whatever treatment they've on, if they may be on some perimenopausal hormonal treatment. But I would be very careful if a patient comes back to you to just say, no, it's fine, it's just perimenopause. I'm not saying I would investigate everyone, but I would definitely investigate somebody that has PCOS. I would definitely investigate somebody that is overweight. I would definitely investigate somebody that has this family history, Yeah, it also depends what it looks like. So if it's just a overall thickened endometrium, there's no cutoff for perimenopause. That's to say, oh, above 20 millimeters. People used to say 8 millimeters, but in some perimenopausal women, the endometrium, and in reproductive age, it can be 10 millimeters, and that's fine. So you can't really use a certain arbitrary cutoff. You have to look at the patient in front of you, and if you're worried about it and you're thinking about it, rather offer it, in rooms or in a hysteroscopy, and get the tissue.
Okay.
You've gone with your life. Yeah.
Did you see that article, by the by, on in the social media about the British women that say that they've been abused by 40,000 hysteroscopies per annum? And that's an interesting question, because they say we're doing too, well, not we, but the guys in the UK are doing too many hysteroscopies. However, I think if you have a case and you don't do hysteroscopy and it's missed, that might even be...
And you're missing cancer. That's worse. I don't know. Yes, we also need to look at the entire, like they say, what's it, 40,000 people that were now harmed. But you must also remember in the NHS, they do it awake. And yes, in certain places in South Africa, we also do it awake without sedation or theatre. So yes, it is an intervention. It's very invasive. Of course, you use your discretion. Yeah, it's not a straightforward answer.
So that's a debatable thing. Now, you mentioned the types of cancers, a poll test to discriminate. What exactly does poll stand for, and what is a poll test? Is it histology? Is it a gene?
No, it's a molecular test. I don't know what it stands for. I don't know. I cannot say. I used to know, but I don't know anymore.
Okay.
But it's a molecular test, and that's why it's expensive. It's not an immunohistochemistry where they just do a stain. With a P53, the one of the others, they can do a stain where they stain the actual tissue and then see which tissues or cells actually stain differently and how they stain. But POL is a genetic molecular test. Yeah.
Okay, thank you. And then, if a woman has fibroids, that does that mean that her cancer is going to be a sarcoma if it's from the fibroids, which obviously puts her in a much higher risk category? Is that correct? Is the treatment or investigation any different if she has fibroids or not?
Look, no. So a sarcoma is a completely different genetic pathway of how the cancer is actually, or how the cancer starts, right? Just because she has fibroids does not mean that she will definitely get a sarcoma. That risk is very low. I think it's quoted as less than 0.1% for a fibroid to turn into a sarcoma. Okay, so that's the one part of it. Anyone with fibroids, even if can still get endometrial cancer, and that still needs to be investigated if they've got symptoms or abnormal bleeding or postmenopausal bleeding. So you can't just say it's the fibroids, but no, that doesn't increase their risk necessarily. I think is that the sort of the question.
Yeah, I think they
Yeah.
mean that if you are a woman that has fibroids, are you at a higher risk or a low risk? The answer is, did you say 0.5% of fibroids become cancer? Is that what you said?
Become sarcomas, leiomyosarcomas, yes. The risk of it actually converting into it is extremely low. Usually leiomyosarcoma from a fibroid is something new that's formed and it rapidly grows. An old one that's been there for years that slowly grows when they still reproductive or perimenopausal they are not usually the ones that become sarcomas, no.
So we've got so many women. A third of women over 35 have got fibroids. Does that mean they have to be investigated if they have normal bleeding or not? Does it make any difference to the workup if a woman does have fibroids with abnormal bleeding? I think that's the intent.
Okay, fine. So remember that a leiomyosarcoma does not necessarily give you postmenopausal or abnormal bleeding. It might only give you that later on once it's invaded into the endometrium. So you need to still investigate, follow the basic rules of above 45, blah, 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 that we've gone through now for endometrial cancer. But it won't cause bleeding early on necessary unless it's one that's in the endometrium, but that's a different cancer. The management for it still surgical usually. Prognosis is usually really not good. They've got lots of pain and a sudden growth. There are many risk factors that we can talk about, but usually for them you don't have to do lymph node dissection. But it's very difficult to really know once you're looking at it if this is a leiomyosarcoma or if this is an endometrial cancer that's just gone through the myometrium, So, yeah, hopefully that's why, you start with hysteroscopy, getting biopsies, trying to get to know the tumor or the cancer.
Okay. Now, there's another interesting question, or at least I think it's interesting. I'll tell you the question. You tell me if it's interesting. Many older women nowadays have cesarean sections because of the increasing age of women having fertility. Is it important, yes or no, to biopsy fibroids at the time of cesarean section in older women because of the possibility of sarcomatous change in these fibroids in the uterus?
No, I don't think so. I think you need to be very careful. If it looks strange, if it looks necrotic, you
Yeah.
can. Just routinely saying you should biopsy fibroids at a 40-year-old that's having a seizure, I don't think is necessarily a good idea. It will bleed a lot. Okay, if it looks like a fibroid, it is a fibroid. It's fine, leave it. If you've been worried about it, it's been growing rapidly. She has got symptoms. It looks necrotic. Something's not right. Yes, biopsy it, of course. That would be my answer. Yeah.
What are those histological types? Now, I'm trying to remember that the type of histology that you'd find that was possible in women that have that biopsy done at cesarean section. You help me here.
You get like red degeneration or the high line degeneration. Are you talking about that in fibroids?
No, there's a histological type that these fibroids become. It's not triple MT. It's
the triple MT.
Yeah.
No. Yeah, I'm not. Yeah.
It's I'll get to the word. Hey, what's that? Stump, yes. My wife just told me it's the stump syndrome.
Oh, yeah. I mean, yeah.
Stump syndrome. You're familiar with that term?
Yes, I've heard it. Yeah, yeah, yeah. I've managed a patient with that as well. Not recently, but a while ago. But yeah, I mean, it's rare. Okay,
Yeah.
it's yeah.
Yeah, so we had the stump syndrome, and the patient wanted another baby, had a baby, and then had hysterectomy done
Yes, yes.
afterwards. Anyway, so that's done. Well, Celeste, I just want to just check if there are any more. We've had lots of questions, but there are no more questions. It's wonderful that we've had you. It's been
Okay.
a lovely, lovely talk, and we've learned a lot, especially about that business about the American ACOG guidelines
Yes,
regarding the thickness of ultrasound endometrial stripes. You say
for
that
postmenopausal
for
women. Yeah.
postmenopausal bleeding, you can get even in atrophic endometriums. Would that be a serous type cancer? Serous.
Usually, yes. But I mean, it can be that you think it's thin, but you're missing the little polyp in the side of the fundus, you know? So it not necessarily, but yes, it can be.
It puts us in a very difficult position because if you have a thin endometrium in a slightly older woman that has bleeding, so that actually begs the question: should they all go for hysteroscopy and some form of biopsy type
That is
intervention?
what
Yeah.
ACOG Americans now say, yes.
Okay, so we're going to be doing even more hysteroscopies.
Yes.
Okay, the British woman is just going to have to suck.
Well,
Okay.
if they've incorporated that into their practice, I don't know. It's controversial. I mean, yeah.
Yeah. Well, Celeste, it's been absolutely wonderful. And thank you so much. I hope you'll be able to come with us on this platform at some stage. We're going to ask 10 questions for CPD points. And a great, great thank you. Next week, we have Dr. Elmarie Besson. She's talking about and AI in our practices and different forms and elements thereof. So it's wonderful. And I'd like to thank Chris for setting this up. It's been lovely for him as always, and we look forward to having you and the rest of us on the platform next week. Safe home, Celeste. Take
Thank
care,
you.
and thanks.
Bye.
Good night.